Well, good day, everyone. Thank you for attending the Regional Community Workshop put on by the International Myeloma Foundation. We are here to help you as a patient, make you grow in your education, and help you with the successes of your marathon, not sprint, treatment in myeloma. Next slide, please. Today, my name is Kelly Cox. As I said, I'm Director of Support Groups and Senior Director of Regional Community Workshops. This is my 132nd workshop. Let me kind of explain that real quick here. We put these programs on 10 a year, and I've been doing this for 19 years or 18 or so. I never get that right. And we put 20 doctors together over a year and 10 qualified nurses that work with myeloma. And they talk about it. They talk about the beginning, what's going on today, how to treat up front, how to treat relapse, what all these terms mean. And we walk you through it. Now, on our website at myeloma.org, I'd like you to just take your time after this meeting and look for acronyms and terms. You'll see it used to be just a couple of pages. Now it's a lot of pages, and I highly suggest you get into that after, because some of the things we're talking about today will make a lot more sense. So next slide. We couldn't do this without our sponsors. I'm grateful for Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, and Takeda. These organizations are very, very much involved with the program, but it's all steered by the International Myeloma Foundation. Throughout this program today, it's very important that you take a minute towards the end or each section to do a feedback survey. This will help guide us for next year in what we're doing for our programs and what areas we go to. So fill them out so we can get back up in this area and present a new program to you. Now, the agenda is pretty simple. You got me right now. I won't be there too much. And then we go into Myeloma 101 and Frontline Therapy with Dr. Craig Cole at Michigan State University, out there where it's cold in the winter and hot in the summer. Then we'll go into a question and answer with a panel, and that will be with both doctors and our nurse. And we're going to take a little meditation and stretch break. I know some people think this might be silly, but we believe in this kind of thing because you're going to get a lot of information and you need to take a breath at this time, because you're going to be surprised at how much you didn't know, and then you're going to feel good about how much you knew. After the meditation and stretch break, we're going to have a new doctor to our regional community workshops, Jesús Berdeja. How do you pronounce your last name?
Berdeja.
Oh, Berdeja. I'm sorry, I just butchered that. And he's an MD at Sarah Cannon Research Institute. After that, we go to how to manage myeloma symptoms and side effects. Patricia Manigan, who has a lot of acronyms after her name, more than I've seen in a long time, is at the University of Pennsylvania, and she's on our great IMF Nurse Leadership Board. Then we'll have questions and answers. So you got a couple times for question and answering after each segment. So you should just know that you can do this through your chat, and we'll get to every or as much questions as we can. Last time we had a bunch of questions and we couldn't get through it. Today, as I said earlier, Myeloma 101 and Frontline Therapy by Craig Cole, Michigan State University, has probably one of the best Myeloma 101 programs out there. So now that I've embarrassed him, take it away, Craig.
Well, thanks, Kelly, and thanks for inviting me. Thanks for everyone waking up and coming in today, and thanks to the IMF for the invitation. And again, I'm Craig Cole from Michigan State University-Karmanos Cancer Institute. And what we're going to talk about today is how common myeloma is, the spectrum of plasma cell disorders, how we make the diagnosis, and what's very important, risk stratification, and how those labs and tests help us risk stratify patients. Then we'll talk about the science behind the treatments, and then we'll talk about upfront strategies for myeloma, including some very, very new information on transplant. Then we'll talk about bone support briefly, then the new stuff, including the evolution and revolution that is four-drug induction therapy for myeloma, and then some perspectives. So myeloma, fast facts. Second most common blood cancer behind the lymphomas. There are 34,000 new cases diagnosed, almost 35 diagnosed last year. And the incidence is slowly rising. But what we will talk about at the very end is how the number of patients living with myeloma is markedly increasing, which is very important. It is a disease of adults. It's diagnosed between age 65 and 74, and it has a significant disparity in the instance between race and ethnicity, as in Black patients have a higher incidence than Caucasian patients and really any other race. And why that is, we're still trying to figure that out. So some of the common signs and symptoms of myeloma is anemia, because it's a disease of the bone marrow. It crowds out a lot of the normal bone marrow, causing patients to be anemic, which results in weakness and fatigue. The decreased kidney function, the protein produced by the myeloma that we'll talk about, gets trapped in the kidneys, causing weakness and fatigue. And those myeloma cells, when they run out of room in the bone marrow, then they go to the bone, thinning out the bone, causing bone damage. I'll show you some pictures about that, causing pain and bone fractures. And then because myeloma goes to the bone and thins out the bone, it releases calcium into the bloodstream, causing the blood calcium to be high, causing frequent urination, loss of appetite, weight loss, and sometimes confusion. And we have an acronym or a mnemonic for these symptoms and signs of myeloma called CRAB that we use to assist us in the diagnosis of the disease. But what's really important to know is about 10 to 20% of myeloma patients won't have any symptoms at presentation. So all myeloma begins with MGUS, the monoclonal gammopathy of uncertain significance. That is when the protein produced by the cells is very low because the number of cells is very low and patients are asymptomatic. It's a very common condition, especially in people over the age of 50, but it has a low risk of turning into myeloma itself. Then smoldering myeloma is when there are more plasma cells in the bone marrow producing more protein. But again, and the normal amount of plasma cells in the bone marrow is about 1%. So if you have 10 to 60% without any symptoms, either CRAB or slim CRAB that I'll talk about in a second, then that's smoldering myeloma with a little bit higher of a incidence of turning into myeloma. And then if you have high-risk smoldering, so that's when the M protein is quite a bit higher, the number of plasma cells in the marrow is quite a bit higher. The free light chains we'll talk about in a second are a bit more dramatic. And if the M protein goes up and up and up, and especially if the hemoglobin goes down and down and down, then we call that evolving type. And that has a higher risk of course, of turning into active myeloma. Then true multiple myeloma is when we do a biopsy and we see plasma cells either on a plasmacytoma or in the bone marrow, and patients present with one of those CRAB criteria, that mnemonic of calcium, kidney disease, anemia, and bone disease. In 2015, we saw that there were patients that had an extraordinarily high risk of developing symptomatic myeloma. And if you have the slim high-risk features, even though if you're asymptomatic, if you have greater than 60% plasma cells in your marrow, if that light chain ratio we'll talk about in a second is very high, if you have more than one lesion on a sensitive scan, then that is high risk of having a symptomatic myeloma, and therefore we decided to call that true multiple myeloma. For MGUS, we kind of watch people because the risk is so low. For smoldering myeloma, we observe our clinical trials. For high-risk myeloma, there's some evidence that maybe treating those patients may help, but primarily most people kind of keep an eye on those patients looking for the evolving type. And for either CRAB or slim CRAB myeloma, those patients are involved in clinical trials or upfront treatment that I'll talk about in a bit. So it's really important to know the labs to follow this disease. The CBC and the comprehensive panel looks at the red count, the calcium, creatinine, and bone status that we had just talked about, not CRAB criteria. The beta-2 microglobulin, the LDH, are two labs that we use exclusively for staging purposes. The beta-2 microglobulin is a protein that's just shed off of B cells, including the myeloma cells. And the LDH is a chemical that's released when cells are reproducing very quickly or if there are a lot of cells. So that assists us in the staging process, but really exclusively used for staging. What helps us determine what the myeloma is doing is the serum protein electrophoresis that tells us how much myeloma there is. That's the M protein that I just mentioned. The immunofixation tells us what type of protein it is, either IgA, IgG, kappa, or lambda. And a free serum light chain, again, is another test to tell us how many plasmas, how much myeloma there is. The urine protein electrophoresis and our 24-hour urine test are tests that we've been using for the past 175 years, but really we use a lot of the light chain assay to determine about, free light chain assay to determine how much myeloma. And those tests are important because they tell you how much disease there is. So the serum protein electrophoresis is basically when we get the blood serum and divide it into its different components, including that gamma region that's at the right-hand side of the slide. And when that protein is very high, that tells us that there's a monoclonal protein there being produced by those plasma cells. Normally, it's very flat, but when there's myeloma cells, it goes up, and it equates to how much myeloma there is in the bone marrow or in the bones. So the higher the M protein, the more myeloma cells there are. And of course, as we treat patients with myeloma therapies that we'll talk about, it reduces the number of plasma cells down and reduces that M protein down. So we don't need to do bone marrow biopsies every month on anyone. We can just do the serum protein electrophoresis test to make sure that you're responding to therapy. Some patients will only produce light chains, and the assay we use to test for how much myeloma there is with the light chain assay is a free light chain test. Normally, we have equal amounts of kappa and lambda light chains, which are these little proteins that hang off the main monoclonal protein. However, if some patients, the myeloma cells will only produce the light chains. And in that case, one of the kappa or the lambda will be very high, and the other protein will be suppressed. And as we treat those patients, the light chain patients with very similar therapy, the kappa goes back down and the lambda goes back up, and the ratio returns to normal. And that's when we celebrate that we know when the treatment has worked. Therefore, it's important to know what the M protein or light chain is being produced, because that tells you that the treatment is actually working. 80% of patients will again have an intact immunoglobulin, IgG, IgA, IgD in some cases, with an attached kappa or lambda. But 18% of patients will only produce light chain, so they'll be using that light chain assay to follow their disease. And a minority of patients, about 2 to 3%, will have non-secretory myeloma, where the myeloma doesn't produce any protein at all. So how we reach the diagnosis is we used to do lots of x-rays. We've been doing x-rays for myeloma since 1900. And we can see lytic lesions on x-rays. But a much more sensitive test is the PET scan. And here is a picture of the x-rays of the skeletal survey that we used to use. And you can see those punched out holes where the myeloma has thinned out the bone. But the PET scan is a much better test, a much more dynamic test to tell us where the myeloma is. And again, it's 85% more sensitive in picking up those lytic lesions. When we get to the diagnosis of myeloma, we'll do a bone marrow biopsy looking for, and these are plasma cells inside the myeloma cells inside the bone marrow, those mutated plasma cells. And in addition to either the Crab or Slim Crab criteria, then we make the diagnosis of myeloma. Again, we do that bone marrow biopsy in order to count the number of plasma cells, but also to understand where the disease came from and to risk stratify the disease. That we get those mutated plasma cells in the bone marrow. It will analyze them to see what went wrong, what mutations happened inside those plasma, those cancer cells, which cause the myeloma, and to re-stratify the myeloma. And the FISH assay, this fluorescent in situ hybridization, gives us an idea of what happened to those chromosomes that cause the mutations in myeloma. More and more, we're using advanced genetic techniques, including next generation sequencing, in order to find more minute but significant mutations that cause the myeloma. Why do we look for that? Because it helps assign patients to either standard risk or high-risk myeloma. That those patients that have high-risk myeloma include deletion 17 or gain of the first chromosome. So instead of having 2 copies of chromosome 1, they'll have 3 copies of chromosome 1, translocations of the 14-16 chromosome, and using that next generation sequencing, you can see if someone has a mutation in P53, a very important gene, which helps the cells necrose and die. And if you have more than one of these high-risk features, they'll call it double hit or triple hit. Standard risk, which is the majority of myeloma patients, can have either triple copies of chromosome, having 3 copies instead of 2 copies, or other translocations such as 11 and 14. And the reason is that it is harder to treat and keep high-risk myeloma under control than standard risk. And that's why it's part of our staging criteria for myeloma. Again, we use that beta-2 microglobulin, those little proteins that shed off of the plasma cells, use that LDH to tell us how fast those cells are producing, and those high-risk cytogenetics. If you don't have any of those, that's stage 1. If you have either the high LDH or high-risk cytogenetics and a high beta-2 microglobulin, that's stage 3. And stage 2 is when it doesn't fit into either category. And part of what we consider high-risk myeloma, those patients that have stage 3 myeloma. So now, how do we treat myeloma in 2022? Well, we use science to treat myeloma in 2022. My little favorite guy, he's been hanging out with me for the past, I think, 15 years. So I love him. And I love these drugs, that they are really revolutionary in treating myeloma. The immunomodulatory drugs, the IMiDs, thalidomide, Revlimid, and pomalidomide or Pomalyst, the proteasome inhibitors, Velcade, Ninlaro, and Kyprolis, we'll talk about those. And the antibodies against myeloma, the immunotherapy, Darzalex, Sarlissa, and Implicity. And there are so many exciting things, other novel therapies that we don't necessarily use for upfront therapy for myeloma, but really are incredible therapies that are coming down the pipeline. And these are the ones that have been approved by the FDA. And there are drugs imminently to be approved by the FDA in the next several months that I just am really excited about. So how do the IMiDs work? Well, there's a plasma cell, and Revlimid especially, and pomalidomide, they use science to treat myeloma and kill those plasma cells. That they barely have a little bit of inhibition of DNA synthesis of myeloma cells, which kills them. And it does inhibit blood vessel synthesis to a very small degree, but those cytokines, VEGF, vascular endothelial growth factor, is what helps keep myeloma cells alive. And so when we inhibit VEGF, then not only does it remove the blood vessels feeding the disease, but VEGF that's required for myeloma to grow and proliferate is also gone, which kills the myeloma cells specifically. But myeloma cells need to be adherent to the bone marrow stromal cells in order to survive and proliferate. That's why myeloma is really confined to the bone marrow and bone compartment. And these drugs, the IMiDs, break that connection between the myeloma cells and the bone marrow stromal cells they need to survive. And without that being connected to those bone marrow stromal cells, those myeloma cells starve to death and die. Those bone marrow stromal cells feed the myeloma cells, especially interleukin-6, in order to have them grow and proliferate. So when that's inhibited, again, those myeloma cells starve to death and die. And there really aren't a lot of other cells that are that dependent upon the bone marrow stromal cells, quite like the myeloma cells. So this is very specific for myeloma. And then when this came out, it blew my mind. that that Revlimid, the IMiD drugs, actually get our own immune system to attack the myeloma cells. Those T cells that should be patrolling our bodies for cancer are actually involved in killing the myeloma cells, directed by the IMiDs to the myeloma cells to get rid of them. An incredible, incredible drug. Thalidomide was the first in class that came out in the 1990s. We found that it was active against myeloma, but had a lot of side effects. So then they synthesized other more potent and less toxic versions of thalidomide, which includes Revlimid, which was approved in 2006. An incredible initial trials showing the activity of lenalidomide for myeloma. In 2013, pomalidomide for relapsed refractory myeloma came out and then was subsequently approved, a bit better in some ways from Revlimid. And more recently, iberdomide, CC220, is in clinical trials, including trials and using it as upfront therapy for myeloma. Very exciting. And the CELMoDs, which I know I've said exciting quite a bit, but I am really excited about the CELMoDs because they are a new class, an entirely different class of the IMiD drugs. And again, more potent than even our most potent IMiD right now, again, early in clinical trials. So the proteasome, we talked about proteasome and inhibitors briefly. Well, what is a proteasome? Well, proteasomes are these little things that are inside our cells, but really, really amplified in myeloma cells. And what do they do? Well, when the myeloma cell produces its proteins, including the functional proteins that have it attached to the bone marrow stromal cells, those M proteins, all those other proteins, well, when those proteins are used up and have sort of lived out their lives in the myeloma cells, then they go to the proteasome. And the proteasome is like a trash compactor inside the cell. It gets rid of those extra proteins and spits them out. So it's like the trash compactor of the plasma cell. And what do plasma cells do? They produce lots of proteins. And so a proteasome inhibitor is like pouring cement inside your trash compactor. Then the dishes are going to pile up. It's like putting a cork in the exhaust pipe of the myeloma cell. And those proteins build up and build up and build up, and the myeloma cells die because and it's like when my kids don't do the dishes pile up and pile up and pile up, and then I get angry. So the first proteasome inhibitor that came out was bortezomib in 2003. And again, is upfront therapy, incredible response rates as compared to the chemotherapy that we used to use in the early 2000s. There was then carfilzomib that came out in 2012, which is an irreversible proteasome inhibitor against myeloma, used initially in refractory myeloma and subsequently used in upfront myeloma. And then more recently, an oral version of Velcade, ixazomib, subsequently came out in 2015 and is right now approved. We've used it as upfront therapy in myeloma and occasionally as a maintenance therapy. So now on to the immunotherapies. And so a bit about myeloma biology. That on top of those myeloma cells, there are an address, sort of a license plate that tells the other cells in the body what a myeloma cell looks like. And including those proteins on myeloma cells, including a protein called SLAM7, GPRC5, FCRH5, CD38, and BCMA, a B-cell maturation antigen. And those are very specific to myeloma cells. Those proteins are very specific to myeloma cells. And what has subsequently happened is that we've made antibodies against those. So antibodies are the proteins that get rid of infection. That antibodies are produced by our bodies, they attach to the bacteria, and they destroy it. But your body isn't making antibodies against myeloma, or else you wouldn't have myeloma. So the antibodies are made in the laboratory against these proteins and is very specific for myeloma, including BCMA, including the drugs of Blenrep and the new CAR T cell treatments that have been approved by the FDA, and daratumumab and Darzalex Faspro, as well as isatuximab directed towards CD38. And we're going to zero in on that CD38. So how do these immune therapies work? Well, one thing that they do is that there's a myeloma cell and there's that antigen on top of it. And when we infuse or give a subcutaneous injection of those antibodies, they immediately attach to the myeloma cell on that antigen, and particularly CD38. And once that man-made antibody attaches to the myeloma cell, it gets our body's natural killer cells, our own immune system, to attack the myeloma cells, degranulate their bullets at the myeloma cell, killing the myeloma cell. Also, when the antibody attaches to the myeloma cell, it activates macrophages. They're the cleanup crew of our body, the cells that clean up any bad guys that are in there. Once those myeloma cells have been targeted as bad guys by the Darzalex or the other antibodies, those macrophages go in, eat up the myeloma cell in hand-to-hand combat. Also, when antibody attaches to the myeloma cell, it activates an ancient part of our immune system called complement, which is a series of proteins that drills holes into the membrane of the myeloma cell, having them die. And actually, when these antibodies attach to especially CD38, it short circuits, it cross-links the CD38, short circuits the cell and causes them to die. Also, when the bone marrow stromal cells, remember, myeloma cells need to be attached to those bone marrow stromal cells. When the antibody attaches to them, the bone marrow stromal cell kicks the myeloma cell out of the bone marrow and they starve to death. In addition to that, the antibody therapies also activate our other parts of our immune system to get to rid ourselves of myeloma. So using these tools, the Revlimid, the Velcade, and Kyprolis, and Nlaro, Cytoxan, Decadron, these and Darzalex, these are the tools of the trade that we put in combination for induction therapy for myeloma. And I highlighted some of the new therapies, including VRD and Darzalex for upfront therapy, and then consolidation and maintenance therapy. So when we treat myeloma, we divide people into transplant candidates and non-transplant candidates. If someone has high-risk myeloma, remember we talked about high risk, we use VRD, and the not transplant candidates, we'll use VRD or DARA-RD. For standard risk patients that are not transplant candidates, very similar, maybe RVD light or DARA-RD. And for our transplant candidates, if they're high risk, we use a KRD with carfilzomib or DARA-RVD, followed by a stem cell transplant. There's standard risk, so we can use RVD or DARA-RVD, and they'll go to a transplant after that, and that's our preferred method, and I'll show you why that's our preferred method. Right before I show you that, I'll show you Dr. Sagar Lonial's iceberg model for myeloma. That when patients are first diagnosed, they have a lot of myeloma cells, so it's obvious they have that crab criteria, and then the iceberg is obvious. But as we start treating the myeloma, we want to bring the protein down. And if the protein goes down 50%, that's a partial response. Goes down by 90%, that is a very good partial response. And if the protein disappears on that SPEP or free light chains, then we'll call that a complete remission. So how do we do that? How can we get those deep responses? Well, I like to think of transplant as the left hook, that when we treat myeloma patients, we use that RVD, punching the myeloma with our right hook. And if you really want to knock the other guy out, you'll hit that left hook, which is the transplant. And just published 2 weeks ago was a trial looking at transplant versus no transplant for myeloma. and where patients that were transplant eligible either received the VRD treatment followed by stem cell collection and no transplant versus RVD, stem cell collection and transplant. All patients got consolidation and then they went on to maintenance. And the whole point was to see, well, did transplant actually extend the time to the next relapse? And we followed those patients for over 6 years. So transplant versus no transplant. Well, who wins? Well, for toxicities and side effects, yes, the transplant wins. Doing that extra therapy to knock the other guy out has a bit more side effects. We'll talk about that in a second. But when you look at how long it took to relapse, it took longer for the myeloma to come back in patients that had transplant than the patients that didn't have transplant. And that was statistically significant. That was amplified. If you have high-risk myeloma, you stayed into remission much longer than you did if you didn't get transplant with high-risk myeloma. But what is important to note is that the overall survival was the same, a transplant versus no transplant, primarily because we have so many awesome good therapies that we can use at the time of relapse. When you look at the duration of the response, knocking the other guy out with the left hook had a longer response. And MRD negativity, those really deep responses, again, better when folks had transplant. One of my patients, and so at 76 months, the risk of progression, primarily progression, was higher in patients that didn't get transplant than those that did. And again, that was statistically significant. One of my patients challenged me in saying, well, what about my quality of life? And this study looked at that. And it showed that the red line was the patients that got transplant. The blue line were the patients that didn't. And yes, there was a dip in quality of life and physical functioning while patients healed from getting the transplant. But afterwards, they returned right back to normal. And in fact, for quality of life, patients that got transplanted a little bit better quality of life at 3 years than the patients that didn't get transplant. So what do we do after transplant? Well, there was a study that looked at that, where patients either got transplant and went straight to rev maintenance versus consolidation with more therapy versus a second transplant. And the good thing is that we found with the stamina trial is that there was no difference in progression-free survival, overall survival between those three groups. So just going straight to maintenance without doing consolidation is easiest. However, there's a question if high-risk patients could benefit from 2 transplants. And with rev maintenance, there are several trials that show that there is a progression-free survival advantage to continuing on maintenance therapy than not. In studies where years and years ago, where patients were either given Revlimid as maintenance therapy or no maintenance therapy, which was a standard of care years ago, there was a modest overall survival benefit and a clear progression-free survival advantage to being on maintenance therapy. Then the question from that trial that I had mentioned, how long should we stay on it? And it appears right now that when patients were either given a choice of stopping maintenance therapy or continuing on maintenance therapy after 3 years, that those patients that stopped maintenance therapy began to relapse. And in these survival curves that I hate to show because they can be confusing, but each little dip down is somebody relapsing. And after 3 years, when patients stopped lenalidomide, they started relapsing earlier and more than those that stayed on lenalidomide. Bone support is really important in myeloma, that those lytic lesions that I talked about, we have to heal those bones because we have such good therapies to treat myeloma. And ways to do that are the bisphosphonates, pamidronate, Zometa, and Xgeva, help build back those bones. But vitamin D and calcium supplements are critical to do that. So make sure that you're on those therapy, that you're on vitamin D and calcium while you're getting those bone strengtheners. Orthopedic support and pain control, very important. And again, in the quality of life. So in the last 5 minutes, I'm going to talk about the new stuff that we're really, really excited about it. absolutely practice changing. The Griffin trial that everybody is on every myeloma doctor and everybody's lips. The Griffin trial was very interesting, and as it compared the standard of care, Revlimid, Velcade, and dexamethasone, versus the addition of a fourth drug, the daratumumab that I had mentioned, that antibody against the myeloma cells. So this in transplant eligible patients, and patients either got the standard of care, Revlimid, Velcade, and dexamethasone, or the addition of daratumumab to that. They then got transplanted, had consolidation, and then went on to a maintenance of either Revlimid alone or daratumumab for a few years, and then Revlimid. And the question was, how did the extra drug work? When you look at the overall response rates, awesome between the two. A little bit better for the addition of daratumumab, an overall response rate of 99%, but awesome response rates. But you look at the depth of response, again, that 90% reduction in myeloma, the VGPRs, greater in the DARA group than in the non-DARA group. Again, nothing to laugh at between the two, but deeper responses in the DARA group. When you look at complete responses, again, higher in the DARA group than in the RVD group, which has really, again, been practice changing. The big news was that as patients were on that maintenance therapy, that their responses deepened even more from that 42 that I showed you earlier down to 66% of patients. Again, deepening response with maintenance therapy as compared to RVD alone. When you look at MRD, those super deep responses where you can't even detect it by molecular means, again, higher in the DARA RVD group than in the RVD group alone. Those deepest, and the deeper you have that response, the longer it's going to take to come back, which relates into the progression-free survival, or the time it takes to relapse, again, higher in the DARA RVD group than in the RVD group alone. Again, the survival curves, I hate showing them, but at each little dip down is someone that's relapsed, and you look at 36 months, the relapses were not significant yet, but very close to significantly different between the two groups. And which is really, I think, where we're going is for drug induction therapy. Lots of trials looking at this, and I'm not going to go through all of these, but gosh, gee whiz, look at these overall response rates, 99, 100%, 100%, 93, incredible, incredible. If you would have asked me 10 years ago, would we have response rates 99 and 100% for myeloma, I would have said no way. And it's incredible. It really is, again, practice changing. So it's important to know some things about myeloma. What are your goals of therapy? I've had patients walk in and have said, I want to be MRD negative for my myeloma. And I say, I can do that for you. Those 4 drug induction therapies. I've had patients that said, I just want a good quality of life. I can do that for you. And so know your goals of therapy. Know how to read your M protein level, because that's when you know when to celebrate, that the number of myeloma cells equals the M protein. And as you treat the myeloma, then that will go down. Know your risk and stage of disease to know which therapy of those super options that we have available is best for you to reach your goals. I'll know your therapeutic options. Again, there's a whole list of drugs for induction and for induction and relapse therapy. Know your treatment options. Be informed. Know your response to therapy. Know when to celebrate when your M protein goes down. That is so important to know when to get ice cream so that you know that the treatment that you have is working. But know the side effects and what to expect, and know who to report them to, and know who's on your care team, and bring your team around you. Just like Kelly mentioned, this isn't a sprint. This is can be a marathon. Have your team around you. always obtain a second opinion. Very important because there's so many new things happening in myeloma, and always ask about clinical trials. That's where we are with 100% and 99% response rates are because of clinical trials. There have been incredible advances in myeloma. We've had 31 new drugs approved since 2015 for myeloma. Outpaces everything else. And the relative survival rate has increased. When you look at how many patients were living with myeloma in 2004 as compared to 2011 and 2019, look how many more patients are alive with this disease compared to 2004. And it's because of all these fantastic new therapies. So myeloma isn't curable yet, but it's survivable now. And thank you.
Well, I've never seen a picture of Michigan State University. Is this one of your offices here?
So we have a brand new cancer center, brand new hospital, which is on the left side, and then our laboratories are on campus, and that's the one with the pretty flowers.
God, it's beautiful. It's nice. Thank you, Craig Cole. That was really great. And you guys see his, can we go back a slide? You see the great place that he's working and that he has an email address. But I wanted to tell you, Craig's talk is really full of a lot of information. We record these meetings so that you can go back and see the slides and listen to it and so forth. So don't sweat it if you're missing things of any presentation here. Now, the next part is I'd like to go to some questions here. Do we have any questions yet? Oh, this is interesting. Which one is better on a proteasome inhibitor, Velcade or lenalidomide Revlimid maintenance therapy? Do you go 2, 5, 10 years longer for myeloma patients? When is a better time to stop maintenance? See, they got a couple of questions there. When to start, what you do in the middle of it, and when do you end it?
So,
anyone want to take that for 1,000 points?
Which one is better? So that's, oh, I love this. If I can answer it, love this question.
Go ahead.
So there was a trial called the Hoban trial that took place a long time ago. I think I may have had hair back when the Hoban went through. And when now I'm trying to think if I had hair. So I didn't have hair when Hoban went through. But Hoban looked at patients that had high risk myeloma and standard risk myeloma. And some of the patients were divided between all the patients were divided between getting a proteasome inhibitor maintenance or getting a IMiD maintenance. And the patients that had the higher risk cytogenetics, specifically the 414 that I had a slide on, the 17P patients, did better on the proteasome inhibitor maintenance than on the IMiD maintenance. And so we have a tendency, and now these days, for patients that have higher risk, we tend to include a proteasome inhibitor as part of their maintenance, and sometimes we even don't stop the IMiD in some of the higher risk patients. For standard risk patients, then Revlimid is very good maintenance, therapy. The $1 million question that we're working at trying to answer, including there are trials like the master trial that are looking to answer when's the best time to stop maintenance, and especially knowing if someone's MRD negative. And I think that we're at, really zoning in on that answer, I think, very soon. It may be a bit, I know that there are doctors that have taken some of the master trial data and have used that in kind of their algorithm. I like to see a bit more data before I stop my patients that are MRD negative and stop their maintenance therapy. So I think we need a little bit more time to help us sort that question. So ask me that in a year, I think.
You bet on it. I'll ask you that now that you've committed to it. Jesus, do you have anything you'd like to add to that?
Yeah, no, I completely agree. I think for the most part, Revlimid is easier. It's oral drugs, so it's you don't have to go to the clinic and get the injections. So that's part of its charm. I think when we talk about the proteasome inhibitors, though, there is some data with Ninlaro, which is the oral proteasome inhibitor, and I think that data in maintenance is not as good as the data with Revlimid. So I think head-to-head, I would still choose Revlimid. But Craig is correct that when we use the proteasome inhibitor by itself or in addition to Revlimid, it's in the high-risk patients. And perhaps in the 414s, you can get away with using it by itself based on the HOVON study, but with other high-risk features, we tend to combine it. And then when to stop, we will all love to be able to tell you when to stop and whether we have markers we can follow. But I will caution you that even in the master trial, in the patients with double hit myeloma that had these two high-risk features who achieved their endpoint to stop, those patients relapse very quickly. So we have to be careful, I think, still.
Fantastic. Since you're speaking, let me ask this question. Are there any clinical trials looking at treating MGUS or smoldering patients in order to prevent the disease from progressing when diagnosed early?
Yes, no, that's a great question. So definitely smoldering. There's a lot of smoldering trials happening, and there's a lot of controversy over smoldering, I would say, right now. Remember that smoldering is a disease that is very variable. There are people that kind of go into different buckets, and the high-risk smoldering patients are the ones that we tend to think of as treating early because they have such a high risk of developing active myeloma. And there's definitely data supporting, in my mind, both continued observation as well as treatment. But there are many trials ongoing for smoldering myeloma. MGUS is a little bit different. I think MGUS, it's, you really are at a point where it's so early, and the majority of people with MGUS will actually never develop myeloma. I don't think we'll live long enough to develop it. So it's really trying to figure out in that bucket of MGUS people, who is the highest risk to develop, where you potentially would target and be willing to entertain some of the potential side effects, not only short-term, but long-term side effects of the treatments.
Okay, along with that same question, Jesus, this person asks, I'm being given conflicting diagnosis that MGUS since 2021, now I'm told myeloma since 2021. So no MGUS at all. How do I get a second opinion? I think we encourage second opinions on some patients, but I'm concerned that this person thought they had MGUS, then went to myeloma. It seems like a diagnosis that could have been more complicated than it needed to be.
Yeah. Well, I think the only thing I would say is a lot of times when your primary care doctor tests the proteins, you're referred for MGUS. And then as the oncologist starts to do more testing, it turns out that MGUS truly is myeloma. And so I'm hoping that's what happened here. It's not unusual for that diagnosis to change like that once you get to more diagnostic tests, like Dr. Cole showed you in his talk.
And if I could add a point there too, that officially people are not considered MGUS for close to a year monitoring your labs. If the workup reveals MGUS in the oncology office, sometimes you're still evolving to myeloma. So, with active, I guess the key here is observation of labs and close active observation is what we call it. But sometimes we're picking up a MGUS that does evolve over that first year to a myeloma.
Active observation is what you said?
Yeah.
I've never.
Yeah.
That's fantastic.
That's my favorite term.
Right.
Because I very much agree with Jesus about smoldering myeloma, and I think that really what we need to do is have patients on clinical trials with smoldering, and for us to really get a better idea of who should be on active observation and who should get therapy. And, there, just a few years ago, 1% of myeloma papers were on smoldering. Now now that whole area has ballooned, including that's the research that we do at MSU, is getting a better idea of the biology of smoldering myeloma. So we have a better idea of how to treat these precursor diseases and who doesn't need to be treated with precursor diseases.
Can you believe you're saying that, Craig? That's just fantastic what you are paying attention to up there. And I know a lot of patients are grateful. Okay, we have a patient on Zometa who has ONJ as well as lesions and has been on 10 years of Iridia. Anyone want to take that one? Jesús, you're smiling.
Well, I mean, I think that, those are very important drugs, as Dr. Cole discussed in his talk, in terms of for bone health and to really strengthen the bone. But that has to be balanced with the toxicities, the potential toxicities of the drugs, and obviously osteonecrosis of the jaw is the most, I guess, feared or that we kind of have to consider, and definitely that increases with time. So the need in my mind, the need for the bispecifics and the antibodies strengthening your bones is really when your disease is active, and once the disease is in remission, that risk of bone deterioration lessens significantly, and I think that's when you can start thinking about either stopping or decreasing the interval of these drugs, and often I usually stop after 2 years of therapy if the patient's in remission. But again, it really depends on, there's really no good data that guides us. It tells us exactly what we have to do. So again, it's balancing those risks and benefits.
Yeah. I think that IMWG, just like you said, that if you hit a very good partial response with 90% reduction or a complete remission, then you can, consider stopping after 2 years. And that's exactly what I do in order to avoid that risk. The one trick is that when patients relapse, then it's a restart. And the fortunate thing that we have is that we can achieve those really deep responses even at relapse with the new medications that we have. So we can limit the amount of time that people are on the bone strengtheners. But even if you stop the Iridia, using calcium supplements and the vitamin D are still important, and getting sunlight to activate that vitamin D, being outside and getting some ice cream are important ways to help maintain bone health.
Let's talk about MRD. Some people can get it and some people can't. Doctors, go each at this. Are you using MRD, or do you feel that's a good testing system? Whatever you'd like to talk about. Craig, why don't you go first?
So that's a super good question. So in a research content, yes, that a lot of the clinical trials that we do like using MRD as an endpoint, because it can help us instead of waiting. I've showed you some of these trials where it takes years and years and years for patients for their disease to change. And we don't want years and years, we don't want to wait years and years and years for results. So the MRD helps us be able to predict how deep those responses are. So in the research content, yes, absolutely. When, outside of clinical trials, I talk to the patient. Like I said, I've had patients that have walked in the door and said, I'm going to be MRD negative. And then I said, okay, we're going to test for MRD after transplant and subsequently. If patients, if their goal of care, when we set goals of what we want for their therapy, if they say, look, all that I want to do is have the protein go down to 0. I just want to get a partial response and then go, kayaking with my family. then I don't check it because the patient, isn't asking for it, and their goals of therapy are different than that. So outside of it, I really let the patient guide me. I haven't quite yet adopted de-escalation of therapy based on MRD. I'd like to kind of see some more data before I do that.
Jesus, that's great, Craig. Jesus, would you like to comment as the last comment here?
Yeah, no, actually, I completely agree. I think eventually it will become a test that we'll do in everybody, just like every other test, to kind of get to that MRD negative state. But right now, like Craig said, we don't have any information on what to do with those results, other than it makes us feel better. It makes the patient feel better that they're on that group that maybe will stay in remission longer. But it doesn't really guide what you do. So the only time I can think of maybe using it is someone who is on maintenance, who is MRD negative and is having a lot of toxicity. We may make it easier to say, maybe it is time to stop just because your life is miserable. But it's really a very specific case in my mind at this point, in terms of, I don't think MRD is quite ready for just standard of care practice.
Okay, so with that last comment, we have it looks like the audience woke up. All of a sudden we have multiple questions. We'll try to get those questions at the next Q&A. For now, thank you everyone for the first talk and Q&A. Now we are going to take a little break, a little meditation where we're going to want you to relax and just think about what you've heard. A lot of it pertains to you guys. So we're going to let this segment calm you down and take a listen to it and take some breathing, and then we'll come back. So production office home, please take it away. Well, how about that? Switch on the machinery. Now, I want to say this much. The switch must be on because we got a lot of questions. And then open the jar of happiness. You got to try to find that while you're going through this to stay clear-headed. And I think what Kelly does is on our website at myeloma.org. She has other mindful kind of things from yoga to meditation. And we think that's a very important part of your treatment. There was a question about second or third opinions. I'm going to address that after Jesús. And without further ado, the next segment is relapse therapy and clinical trials. Relapse therapy and clinical trials with Jesús. And why don't you take it away, Jesús?
I will. Thank you so much for having me. And again, thank you for the invitation to IMF. And just so we're clear, Kelly, you're not the first person to not be able to pronounce my last name. As a matter of fact, I mispronounced it myself as well. So, but it's Jesús Berdeja.
I'm so sorry. I'm dyslexic, so it happens.
I'll have you know that I was in a conference and I actually asked the chair. I said, "Do you know how to pronounce my name?" He's like, "Yeah, it's Berdeja." He's like, "Okay." He's like, "Yeah, thanks for letting me know." And so we talked about it. And he gets up to introduce me, and he completely forgets and butchers. So see, you wouldn't even so.
Okay. Thank you so much. Thank you.
But without further ado, we'll get going here. And my topic today is to talk about relapse myeloma and touch a little bit on clinical trials as well. So these are my disclosures. But first, some definitions, I think. So what is relapsed and refractory disease, and what is a line of therapy? So, relapse, you always talk, your doctors talk about it, but so relapse disease is after when your myeloma comes back after you've had a response to therapy. That is what's considered relapse. Refractory means that myeloma progresses even while you're still on therapy. A line of therapy is a treatment that is planned, that is given until progression or is changed because of side effects. So for example, when you have induction or your initial therapy followed by a stem cell transplant, followed by consolidation, followed by maintenance, that is all planned. You're still in a remission. And so that is considered all one line of therapy. So I think that's important to note, just because sometimes drugs get FDA approved for so many lines of therapy and people get confused whether they're candidates or not. So in terms of the available anti-myeloma agents, we have a lot of choices. And so I put them here sort of by category. So we have the steroids, we have conventional chemotherapy like melphalan and Cytoxan. We have the IMiDs that you heard about, the thalidomide, Revlimid, Pomalyst, and the proteasome inhibitors, Velcade, Kyprolis, and Laro. We have the monoclonal antibodies, and I just realized that I forgot one. So we have Implicity, Darzalex, and Sarclisa, which is isatuximab, which is the other anti-CD38 antibody. So I apologize for that. We have some newer agents that are also FDA approved now, Expovio or selinexor, as well as Blenrep and Belamaf. And now we have 2 CAR Ts that are approved as well for relapsed refractory disease, Abecma or ide-cel and Carvykti and cilta-cel. But we have so many choices. So how do we actually choose? That's $1 million question. So before we go on to how we choose, I think there's a couple sobering things. So one thing we know is the first time we treat myeloma, we have the best chance of getting the longest duration of that remission. And as the disease relapses, each subsequent remission lasts less and less. And that's what the graph on the left is showing. On the right is a study that was done looking at the percentage of patients that actually got to different lines of therapy. And you can see that there is this so-called attrition, meaning that most patients get that first line, but even by the second line, there's a significant number of patients that don't get a second line of therapy and even less of third line. So I think keeping this in mind, it's the whole idea of, do you keep therapies for a rainy day or do you go in with your best foot forward? And I would say that based on this, I would go in with my best foot forward at each time because of these sobering statistics. So in terms of how you choose, I think there's many ways to discuss this, but I call it the 4 Ps of treatment selection. And on the left are things specific to the patient. So patient characteristics, the age, how frail is the patient or how fit is the patient, and whether they have other comorbidities. Do you have heart disease, kidney disease, diabetes, etc.? And then you have the patient preference. What are the goals of the therapy? And Dr. Cole alluded to this a little bit in terms of, do you want to reach those really deep remissions? Do you want to just get the disease under control and maintain the quality of life? Do you prefer IVs versus orals, et cetera? All that is taken into account. On the right, we have things that are more specific to the disease itself. So we have the pathophysiology of the disease, which is, what is the tempo of the relapse? Is this progressing because your protein is slightly increasing, or are you developing new tumors? Are you breaking, do you have new bone lesions? Do you have a high calcium? What is the genetic profile of the disease? Do you have high-risk disease? Do you have these high-risk features that would make the disease much more difficult to control, for example? And then you have to take into account the prior therapies that you've received. So what you received before will guide what you are eligible for next, or what will actually work for you next. Also, how well did you do on that treatment? What kind of remission duration did you have? Did the disease work and then stop very quickly, or did you stay in remission for a long time? And then, of course, what toxicities have you had from those treatments? Because you obviously don't want to compound those. So when we're looking at treatment options, I think when we're looking at early relapse, the question is, are you still a candidate for Revlimid, or is Revlimid still the preferred agent? And if that's the case, we have 4 large randomized studies that I put here, looking at triplet or 3 drugs. So Revlimid, dexamethasone plus a third drug versus Revlimid and dexamethasone. And you can see basically the point of this is that every time we compare a triplet to a doublet, the triplet is better. So in the Pollux is a Darzalex with Revlimid and dexamethasone versus Revlimid dexamethasone. You see that there's a significant improvement in the progression-free survival, 44 months versus 17 months. Same when you add Kyprolis, for example, to Revlimid dex versus just Revlimid dex, is a significant improvement in progression-free survival. The ELOQUENT-2 study showed that if you add elotuzumab or Implicity, which is monoclonal antibody, to Revlimid dex, there is about a 5-month improvement in progression-free survival. And then on the far right is the addition of Ixazomib or Ninlaro to Revlimid dex, again, about a 5 to 6 month improvement to progression-free survival. What if you are not a candidate for Revlimid-based therapy, or you prefer to use a proteasome inhibitor instead. And in that scenario, we also have a few studies that have shown a benefit to the use of 3 drugs versus 2. On the left, you see the CASTOR study, which is actually Darzalex, Velcade, and dexamethasone versus Velcade and dexamethasone. And you see that the progression-free survival of the PFS there in the middle significantly improves with the addition of Darzalex, 16.7 months versus 7.1 months. The Endeavor study actually was very interesting because that is actually a doublet against a doublet. It's just that it's Kyprolis against Velcade. And there you see that there was actually a significant benefit to the use of Kyprolis over Velcade, almost a doubling in the progression-free survival. So in my mind, before the studies to the right came out, that was probably the only doublet that I would recommend sort of in the relapse refractory setting if you wanted to be aggressive. But now we actually have data with the CANDOR and IKEMA studies on the right there, which is basically looking at the addition of an anti-CD38 antibody. With the CANDOR study is Darzalex with Kyprolis Dex versus Kyprolis Dex. And then on the right is Sarclisa or Ixazomib, Kyprolis Dex versus Kyprolis Dex. And you see that there's a significant benefit to the addition of the Darzalex to just the Kyprolis Dex alone. The progression-free survival has not been reached for either of the triplet combinations, but the hazard ratio, which is actually telling you sort of the decrease in progression or mortality for patients as the number goes down, that indicates a benefit to the triplet. And so hazard ratio of 0.63 and 0.53, you're almost having, cutting in half the progression and mortality. So significant benefit to the triplet in my mind. So what about if you're progressing later or your doctors don't feel that a proteasome inhibitor or a Revlimid is an option? We do know we have now several combinations looking at triplets versus a pomalidomide-based doublet. So the first is Optimism, which is looking at Pomalyst, Velcade, and dexamethasone versus Pomalyst and dexamethasone, and you see that that actually shows a benefit to the addition of the third drug, the PFS of 11.2 months versus 7 months. The Eloquent study looked at adding elotuzumab or Implicity, a monoclonal antibody, to Pomalyst and Dex versus just Pomalyst and Dex, and again, a significant improvement to the triplet. And then on the right, you have the addition of the anti-CD38 antibodies, so Apollo with Darzalex and Icaria with Sarclisa, and you see that the addition of the anti-CD38 antibody almost doubles the progression-free survival. So again, showing a benefit to the triplet versus the doublet. So what do we know? So we know we have a lot of options, so that's good. Consistently, triplets have been found to be superior to doublets in randomized phase 3 trials. We know that treatment until progression or intolerance is important, and that it should be the paradigm in the relapse refractory setting, unfortunately. Triplets in general perform better in patients with poor risk cytogenetics, but they don't overcome that risk. So unfortunately, having high risk cytogenetics, patients still don't do as well as patients with standard risk, even with triplet therapy. What we don't know is there are no head-to-head comparisons between these triplets to help us guide with selections. So I can't tell you, we can just go again by what you've had before and what makes the most sense, but I can't tell you head-to-head, this triplet is better than that triplet. It's also important to remember that it's difficult to compare between studies. So the patient populations differ quite a bit between the studies. And if you actually look at the different triplets that use the same doublet comparison, the outcome of the doublet in the different studies is very different, which tells you that obviously the patient populations were very different. So just kind of keep that in mind when you're looking at absolute numbers. So we've had a lot of progress and there's a lot of good options out there. But again, another sobering fact here, this was the Mammoth study looking at patients who had received an anti-CD38 antibody and had progressed on that. And unfortunately, patients do not do well once that happens. And if you look at the graph on the right, the middle curve there is patients who are considered triple refractory, meaning that the disease has progressed on either Revlimid or Pomalyst or Velcade or Kyprolis or Darzalex or Sarclisa, you see the median overall survival is just 9 months. So clearly a lot more to be done. But luckily, we do have a lot more once we get to this stage, which is good. So one of the drugs that is available to us now, sort of in that sort of triple refractory state, is selinexor. And selinexor is very unique. It basically blocks exportin 1, which is needed for the cells to get rid of certain proteins, in particular certain proteins called tumor suppressor proteins that basically help the cell survive. And so by actually blocking that, it induces what we call apoptosis in the cell, the myeloma cell dies. And so selinexor is an oral medicine that was approved based on the study on the left, which is the STORM study. And in the STORM study, patients were very heavily pretreated, had prior 7 lines of prior therapy, and 96% were refractory to the 5 classes of 5 different drugs: bortezomib, Revlimid, carfilzomib, pomalidomide, and Darzalex. And as you can see, there was an overall response rate of 26%, which doesn't seem that great, but just to remind you that Pomalyst and Darzalex and all these drugs that were approved as a single agent in this setting, and potentially one can argue in populations that were not as heavily pretreated or refractory, had those same overall response rates. So this is actually what we expect in this setting. Median progression-free survival of 4 months. So that got this drug approved for patients who've had at least 4 prior lines of therapy. There has, as we tend to do in myeloma, we start combination studies with these drugs because we think there'll be, we know they would likely be more active in combination, also earlier in the line of therapy, or in earlier lines of therapy. So the phase 3 Boston trial proved that if you add selinexor to Velcade and dexamethasone, you have a significant benefit. And so here we see that the median progression-free survival with the additional selinexor to Velcade was 14 months versus 9.5 months. With a significant improvement in the duration of remission of 20 months versus 13 months. So again, this is an option now as well in the earlier setting. Now, selinexor does have some toxicities that are important. It's an oral drug, but it does have significant GI toxicities. So it's important to note that those are possible, and you want to be proactive with preventing them instead of kind of chasing down side effects. Next, we have we now start the barrage of the new darling target for myeloma, which is BCMA. And BCMA is, as Dr. Cole showed you in his talk, a protein on the surface of the myeloma cell that is very specific to plasma cells, and in particular myeloma cells. And so this is an antibody-drug conjugate. An antibody-drug conjugate, the idea here is you have a monoclonal antibody, not too dissimilar from Darzalex or Sarclisa, but this antibody now is linked to a payload, which usually is a chemotherapy. And so when the antibody binds to the cell, the whole complex gets internalized, and the chemotherapy is delivered. It's almost like a Trojan horse that can kill the cells from inside. And so the drug that is sort of the leading the way, that is now FDA approved in terms of the antibody-drug conjugates, is called belantamab mafodotin, or Blenrep, which is a little bit easier to say. And so this is an antibody, a monoclonal antibody against BCMA that is bound to this payload called MMAF, or monomethyl auristatin F. And so again, on the right, you see a little bit of the mechanism of action where basically the antibody binds BCMA, gets internalized, and then the MMAF is released inside, killing the cell. At the same time, the antibody actually can attract cells from your immune system that can also lead to this a mechanism called ADCC, that another way of killing the cells from outside. And so for various reasons, this leads to myeloma cell death. So belantamab mafodotin was FDA approved in August of 2020, and it was approved for patients with relapsed refractory myeloma after 4 or more prior lines of therapy, including an anti-CD38 antibody, a proteasome inhibitor, and an IMiD. And so that was based on the DREAM2 study. And so the DREAM2 study here is the one the second one, but I'll talk about the DREAM1 first. So that was the first study that looked at this antibody-drug conjugate. And as you can see, it was given a little bit higher dose of 3.4 milligrams per kilogram, and saw impressive results of 60% with a median progression-free survival of 12 months. Again, usually we're not used to seeing those kind of numbers in the relapse refractory setting. But this study actually was done mostly in Canada, or accrued mostly in Canada, where actually the anti-CD38 antibodies were not FDA approved at the time. And so a lot of these patients had not had an anti-CD38. And so when the DREAM2 study was done, that required patients have exposure to prior anti-CD38 antibodies. So the population is much more refractory, similar to what we discussed before with selinexor. And here, looking at 2 different schedules, you saw that the overall response was much more to what we're used to seeing in this setting of about 30 to 34%, with a median progression-free survival of 3 to 4 months. So again, very similar to what I just showed you with selinexor, similar to what we saw with Darzalex and Pomalyst before that. Now, with these new therapies, we have new toxicities. And so belantamab mafodotin, or Blenrep, for the most part, is pretty well tolerated. It is given intravenously every 3 weeks, so that's nice. But one of the potential side effects that was seen is that you can get these deposits of protein in the cornea of the eye. It's called keratopathy. And so when in the studies, about 2/3 of the patients had evidence of keratopathy on exam. About half the patients had some symptoms of dry eyes, blurred vision, changes in vision. And so because of this, it is required that when you're on this drug, that you actually be seen concurrently with an optometrist and ophthalmologist that will do a test before each dose to make sure that this is not getting worse. The good news is, if you actually pay close attention to this and you hold drug or do dose reductions, most of these symptoms or most of these changes do improve and go away. But because of that, it does include this much more constant vigilance. So just kind of realize that that's part of what comes along with this new drug. And then there's CARs, right? So we thought we knew what CARs were, but in myeloma, we have a different CAR. And so here we have a CAR T structure. So the CAR itself is really what we see on the left, which is called a chimeric antigen receptor. And basically, this is it's made up of 3 parts. You have a tumor antigen binding domain, and then you have that is fused to a T cell costimulatory domain, and then a T cell receptor activation domain. And so this sort of is it's like an antibody that directly can activate the T cell. And so this CAR, or this new chimeric antigen receptor, can be placed on the surface of T cells, and so these are called CAR T cells. And so I have a little cartoon here of how these work. And so you use viral DNA to insert this new DNA into the T cell that leads to expression of the CAR. The CAR now enables the T cell to recognize the tumor cell antigen, and once it does, and once it binds, the CAR T cells multiply and release cytokines that lead to death of the myeloma cell. Now, CAR Ts are a little bit different than all the drugs we have talked about. Every other drug until now is something you can give off the shelf. Your doctor can prescribe and is given to you right away. CAR Ts have to be manufactured, and these are called autologous CAR Ts because of that. So this is just sort of kind of the journey of what patient goes through for CAR T cell therapy. So first, you undergo apheresis. So those of you who've gone through a stem cell transplant know what this means. So basically, your blood goes through this machine, and before transplant, you get your stem cells collected. For CAR T cell therapy, you get your T cells collected. Once the T cells are collected, collected, then they go off to be manufactured to create those CAR Ts. And that process can take from 10 to 28 days. So it's really about a month before you come back for the actual treatment. And once you're ready to receive the CAR Ts, you go to step 3, where you receive your lymphodepletion, which is low doses of chemotherapy, really to subdue your own T cells so that when the CAR T cells come in, there's little competition. They're allowed to expand appropriately, and then you get the infusion of the CAR Ts. So during that month, during the manufacturing, unfortunately, your myeloma can progress. And so a lot of patients require what we call bridging therapy, where you give some form of myeloma therapy to try and keep the disease from progressing significantly while we're waiting for the manufacturing of these CAR Ts. So we have 2 CAR Ts against BCMA that are FDA approved. One is called the Abecma, or idacaptogene biclocel, also known as ide-cel, and Carvykti, which is ciltacabtagene autoleucel or cilta-cel. Both have the same indications. So patients with myeloma after at least 4 prior lines of therapy that have included a prior IMiD proteasome inhibitor and an anti-CD38 antibody. So what led to these approvals? So for Abecma, the KarMMa study led to its approval. And so on the left, you just see the structure of Abecma. Again, this is a CAR T that against BCMA. So patients were very refractory. They had at least 6 prior lines of therapy, and they were treated with 3 different doses of Abecma, 150, 300, and 450 million CAR T cells. And so on the very far right, you see the overall response for the entire population was 73%, with 33% achieving complete remission. Compare that a little bit to what I told you of what we're used to in this population with things like selinexor or even Blenrep, where we saw overall response rates of about 30%. And I didn't show you this, but almost basically 0% complete remissions. So again, these are very active therapies, which is what all the excitement is about. On the left, you actually see the response rate by dose level. And so you can see that the patients that got the 450 million cells, the 450 to 10 to the 6, actually did the best. They had overall response rate of 82% and a complete remission rate of 39%. This is the progression-free survival and overall survival. Sort of ignore the other curves, but for the most part, this it just tells us that the median progression-free survival was about 8.6 months, and the median overall survival is 24.8 months. So fantastic results. And then if you actually look at progression-free survival by dose, you see that on the very top, you see the green curve. On the left curve, you see that the top curve is the green, and that is the 450 million CAR Ts, and those patients did better with a median progression-free survival of 12.1 months. And then if you actually look to the right, you have the duration of response by best response. So on the very top, you have the patients that had the deepest response, with patients who were in complete response or stringent complete response. You see that those patients in the, I guess, the baby blue there on top had a median duration of response of 20.2 months compared to patients who did not achieve that depth of remission. So again, these drugs can induce very deep remissions that can be very durable for some patients. So this is the study that got cilta-cel approved. It's called CARTITUDE-1. And again, similar population, relapsed refractory with a median 6 prior lines of therapy. One of the things I will mention with cilta-cel that differs it a little bit from ide-cel is that cilta-cel actually has 2 binding domains that bind it to BCMA, whereas cilta-cel only has 1. And so that may make it a little bit different differs from the other CAR T. So response rates, I think Dr. Cole was talking about response rates of 99 to 100% that in the frontline setting. I mean, overall response rates of 98% here in the relapsed refractory setting with this CAR T. I mean, just spectacular. There's things that we would never have even thought of, with stringent complete remission rates of 82%. So again, very powerful therapy, thus the excitement. If you look at the actual PFS and overall survival of this particular CAR T, we see that actually that is looking quite good at a median follow-up of 27 months, the median progression-free survival on the left has not been reached, but 64% of patients remain in remission. And then if you look at overall survival, again, the median has not been reached, but 70% of patients remain alive at 27 months following this CAR-T. So we have new types of side effects with these new products. So we talked a little bit about the corneal toxicity seen with the antibody-drug conjugates. Again, that seems to be specific to the payload that is being used for the antibody-drug conjugate. The corneal toxicity, as long as it's monitored closely, tends to be reversible once the drug is stopped or dose reduced, but it does require close ophthalmology evaluation. Cytokine release syndrome and neurotoxicity are two particular toxicities to what we call the T-cell redirecting therapies, which CAR-Ts are one of them. The other one are the bispecifics, which we don't really talk about very much just because there's none that are FDA approved right now. But these therapies are basically activating T cells. And so by doing so, these T cells release cytokines that allow them to divide and expand, which is what you want them to do. You start with so many CAR-Ts and then you end up with a lot more. So as these T cells are expanding, releasing cytokines, there is this condition called cytokine release syndrome that we have to be careful about. And this is probably the best way to describe cytokine release syndrome is what we see with infections. So when you have the flu, for example, you may get fevers, you may have body aches and just feel kind of blah and tired. That is what low-grade cytokine release syndrome feels like. It's not necessarily dangerous, just don't feel great. But then if you have a really aggressive infection and you go into this condition called sepsis where your blood pressure drops and you might end up in the intensive care unit and you could potentially die from it, that is what high-grade cytokine release syndrome is. So again, it needs to be, we need to sort of respect it and address it quickly. Luckily, we have drugs that actually, when given timely, can completely reverse this process in a matter of hours. The most commonly used is tocilizumab. You'll hear toci used a lot. And when you get that medication, if you have a high enough cytokine release syndrome that requires it, it tends to reverse the symptoms very quickly. But because of that, these are drugs that, or the CAR-Ts for now, are very restricted in terms of where they can be given. The other potential toxicity is neurotoxicity. This one we don't understand as well, but we know that it can happen with these types of therapies. The symptoms usually are very mild with these BCMA CAR-Ts, meaning that your loved ones may notice that you're having a hard time finding words, just like I am right now, or maybe have a little bit of confusion, but then it's very mild and it goes away. But it can be severe to the point where you can have stroke-like symptoms, you can actually have seizures, and you can go into a coma. And so obviously those are high-grade neurotoxicities. And so the good news is those are very rare. Neurotoxicity is very responsive to steroids. And so oftentimes dexamethasone, which you all know very well, is used in the setting and tends to reverse the process. I didn't go into it, but with cilta-cel, there were some sort of late neurotoxicities that we're seeing. These tend to, so these cytokine release and neurotoxicity tend to occur early in the course. So soon after you get the drug, sort of within the first week to the first 2 weeks. It's rare that it goes beyond that. But there were a few cases of late neurotoxicity that occurred about a month later. That was very different. That was more sort of kind of movement type disorders that we're seeing. So just that's the reason that we kind of talk about sort of the acute and the longer term toxicities and why we kind of keep a close eye on you following CAR-Ts. So the take-home points from this part is, in general, we treat to maximum response, balancing toxicity. Triplets in general are better than doublets in all lines of therapy. Obviously, quads or 4 drugs are already being tested in the frontline setting, as we heard, and they're now being looked at also in the relapsed setting. So more to come on that. We have lots of options, but again, no head-to-head comparison of any of these sort of triplets or multi-agent combinations. So again, the optimal sequence is unknown, and you really need to use what I call the 4 Ps to help choose and individualize the next best option for any one particular patient. So don't compare notes. So somebody might have a different drug combination than you, but that has to do with what they've experienced. So it's not always, again, one is not necessarily better than the other. And I think it's because of this, all these advances don't happen out of, thin air, right? So it's very important to participate in clinical trials. So with that transition, let's talk about clinical trials. So I used this cartoons a long time ago, and I think it's just so funny. So I'll just read this one. So I heard there's a drug in trials that might stop my cancer. Great. Are you going to volunteer to participate for the trial? Of course not. Why would I do that? I wouldn't either. Sure hope they get some results soon, though. So why should you participate in clinical trials? So again, major cancer organizations, the NCCN, ASCO, ASH, ACS, all recommend participation in clinical trials whenever possible, not just as last resort. I think a lot of us think that clinical trials are only when everything else has failed, and that's not true. There are trials in all stages of disease. Again, the reason Dr. Cole could tell you that a quadruplet incorporating Darzalex to RVD may be better than RVD is because that was a frontline trial, right? So those patients had not been treated. They went into a clinical trial without having had prior therapy. So again, it is important to consider trials at all stages of disease. So when we talk about trials, you will hear phase 1, phase 2, phase 3, phase 4. Phase 1 are the trials of really new medicine where the truth is there's no human data, and we're really trying to figure out if there's if it's tolerable, if there's no significant toxicities to the drugs. Once it looks like it's a safe drug and maybe there's an inkling that it might be active, then it goes into phase 2 trials for the most part. And that's when you try to really assess how effective this drug may be. And then once you have that data, then you may take it to a phase 3 trial where you actually compare it to standard therapy and try to prove that this is better than your standard therapy. And then phase 4 clinical trials really are more sort of long-term trials looking at to make sure there's not going to be any strange toxicities, or perhaps looking at cost effectiveness, sort of later stages of development once the drug usually has been FDA approved. So all major medical advances are developed through clinical trial testing. So clearly very important, especially in a disease like ours. The safest way to test new drugs or new combinations of existing drugs is through clinical trials. And this is really the best way to ensure results can be interpreted. So I just talked about sort of comparing between different trials and how there's so many caveats and how the populations may be very different. So again, that's why the randomized clinical trial is considered sort of our gold standard in terms of trying to determine whether something is truly superior to another drug or combination. So many reasons why clinical trials. For you in particular, obviously, you help move the field forward. You will help others in the future. You have access to the newest treatments. So I have to tell you, I've had, if the CAR-Ts or cilta-cel was just approved this year, for example. I have, and ide-cel was approved at the end of last year. But I have a patient that started getting CAR-Ts about 6 years ago, and I have a patient that actually has been in remission for 5 years after ide-cel, now ide-cel. Used to be called BB2121. Again, those patients had access to these drugs much earlier. So that's another reason to consider clinical trials. You will get much more supervised care. So with clinical trials, we want to know about everything. We want to know about every significant, any potential toxicity that may happen. And so you're going to be watched over like a fine-tooth comb to make sure that we're not sort of leading to some odd toxicities. We want to know about everything. So I think that's always also very important. You get a dedicated team because you are in a clinical trial. And of course, you help advance medical care. So what is involved in a clinical trial? The consent process is the most important. There's Part of the reason clinical trials can be very difficult for a lot of people is that there's mistrust of the medical community, and for good reasons. We have a long history of experimenting on people without their consent. But because of that history, there's been lots of advances, and there are now a lot of organizations that oversee the development, the ethical development of clinical trials and that requires what we call the informed consent. And so that is the first step for you to participate in a trial, is to actually consent to the trial. And no study procedure can be conducted without an informed consent. And the important thing is that you can revoke that consent at any time. So you're not signing up and then now you're stuck. You can actually revoke that consent at any time. You are in control. Once the patient signs consent, then you go through a screening process. And all studies have very rigid inclusion-exclusion criteria, and that is actually probably the most frustrating thing for a lot of patients to understand. When something is FDA approved, your doctor and you can decide whether this therapy makes sense for you and whether the risks and benefits make sense for you. In the clinical trial, unfortunately, it's the trial that decides that, and so you have to check off all the boxes, and if one box is not checked, we can't do anything about that, and you may screen fail. But so that's sort of when that screening process begins after you consent. And then if you meet all the eligibility criteria, then you start the treatment on the clinical trial. And then after the study, of course, you continue to be followed. It's on the right there. Unfortunately, sometimes it can seem like there can be a lot of forms and a lot of questions. But again, you are overseen so closely because these are all new drugs and we want to develop. So every time you see those commercials with the litany of side effects that come at the end, that's all because of clinical trials, because we want to know about everything, and everything gets put on there that potentially could happen, whether we think it's truly related or not. So just kind of keep that in mind. And so in terms of finding out about clinical trials, many ways: ask your treating hematologist, oncologist about any available trials. You can check with any academic medical center close to your home. You can contact support organizations like the IMF, of course. Visit the NCI website, which is clinicaltrials.gov, that lists all the trials that are available throughout the country. For example, for us, you would go to our website and you can ask Sarah about clinical trials. So many ways, so please be very vocal and proactive about clinical trials. Because I think they are an important component, and especially in a disease like ours, where there's still so many unanswered questions, where we need to keep moving field forward, which has been, again, dramatic, fantastic. I completely agree with Dr. Cole that it's, I mean, we're all so excited to be involved with this field just because it's been so rewarding to see these advances in such a short period of time, I would say. So with that, Shiri will stop, and I guess we'll move on to the next section. So thank you.
Oh, sorry, I'm muted there. I'm not now. Thank you so much. I think some of the things I wrote down here, how do we choose? I think the patient really needs that and get professional opinions. I can't stress enough in my 20 years, got to find them, because they know what's going on. So I think you saw that in both presentations. I do have a couple questions. Panelists have any recommendations about lifestyle, diet, etc.? Lifestyle, just stay up on it, I guess, and dexamethasone more based. Oh, I see this question about gentlemen and Pamela. Do you kind of thing a lot? Dr. Cole? Oh, you're muted.
Yeah.
Here we go.
I think that you're going in and out, but I think the question was about lifestyle, and I married a dietitian to help me with my lifestyle. I hope she's not hearing this.
That's why I wanted you to answer this.
but one thing, but she is a cancer dietitian, and she's a registered dietitian. I met her at the cancer center, and And one thing, which is, I think, really important is, to, watch your weight, watch, healthy eating, fresh fruits and vegetables, limited processed foods, and exercise. There's a plethora of data talking about obesity and outcomes for myeloma and for smoldering and for precursor diseases. And so really, being, kind of cognizant about weight, and which dovetails into, eating smart, and exercise. And of course, exercise also helps the bone health. It's one of the most important things to help build the strength of your bones is exercise. So.
Yeah, no, I agree. And I think the other thing that's important also is there's some certain dietary changes to sometimes help with some of the side effects you could experience. So if you're on Revlimid and you're having issues with diarrhea, for example, so decreasing lactose and sort of certain types of foods may actually help with that, increasing fiber, etc. So definitely, I think incorporation of a nutritionist is important, at least to kind of help navigate living with myeloma and its treatments.
Okay, that's a great response. Let's see. We have part of that question was anything other maintenance that can extend remission. This person's concerned about is their remission. They've been involved with this for 2 years, and the same person asked about diet or lifestyle. But should I consider myself at elevated risk for other forms of cancer? Anyone want to take that? Jesus, you're smiling. You're up.
So unfortunately, the short answer is yes. So anytime you have one cancer, you're high risk for another. The treatments that we do for myeloma can increase your risk for a second cancer, and that includes chemotherapy, and that includes Revlimid, for example. We know that there's an increased risk of what we call secondary malignancies. Those risks, however, are very, very small. So even though it's increased, the overall benefit of the treatment is significantly outweighs that potential secondary risk. But unfortunately, yes, there is a secondary malignancy risk with some of these therapies.
Well, I would assume if you're being monitored, they would catch these kind of things or this type of cancer earlier, and that's what's important about myeloma, to be monitored, as you guys have said. So that's a good point. Revlimid for 2 years now. Okay. Discussion on repeat let's talk about repeat transplants, a second stem cell transplant. Now the blood tests are good, lesions found in the PET scan. So let's talk about PET scan first and then repeat transplants. Anyone want to take that a little bit? Craig?
Yeah, I'll take the PET scan. What's really important to do is that there are when patients relapse, usually they'll relapse with a biochemical relapse. The M protein will be low, and then will start to climb. And as soon as it starts to climb, what's really important to do is to assess: are you starting to get those the crab mnemonic that I mentioned earlier? And especially the bone part. Are you getting hypercalcemic? Are you having anemia, renal insufficiency? But that bone part is really important to assess by doing a PET scan, which again is a very sensitive test to pick up lesions that are in the bone that other tests may not be able to pick up. So I love PET scans. And for second transplant, usually that is a treatment option when patients have a relapse. Usually you can count on, if the first transplant lasted more than 3 years. So if you're in remission for more than 3 years, 3 or 4 years, you can consider repeating the stem cell transplant. Kind of in the modern day, what we frequently use, that patients live a long time with myeloma these days. They go through a lot of treatments, and their bone marrows can get really, their bone marrows don't bounce back as quick. So sometimes we actually do transplants to improve the blood counts of patients. So when they're ineligible for clinical trials because their platelet count is too low, or they're getting transfusions because their bone marrows have seen so many different lines of therapy, sometimes we'll just go back to those stem cells that are 10 years younger than you are currently, and then use the transplant to improve those blood counts. So I wish I could go back in time and get my hair stem cells from 10 years ago to grow hair, 20 years ago to grow hair, but you can definitely do that with the stem cells.
And I'll just add to the second transplant, I didn't show that as part of the treatment options, but that's definitely still a very viable option, especially for patients who actually did not have a transplant in their first treatment that chose to delay transplant. There's definitely good data that that having a transplant in that second remission is important for patients who delay transplant. But a true second transplant is the difficult part is the data with that sort of is before we had all these triplet therapies that I recommended. And so
test 1, 2, 3.
It's hard to know, when to actually incorporate it or whether it will do any better than these therapies. So again, it's very individualized. But like Dr. Cole said, if you had a really prolonged remission from your first transplant, it's definitely a very good potential good option for you as well.
Take it away. Can you guys hear me okay?
Yes.
Okay, you can. I can't hear you, so I'm just going to bear through this last part here. Both doctors here are qualified multiple myeloma doctors, and I can't stress that enough. You need to go to our website, get the terms and acronym sheet, and understand what they're talking about, because we all have a limited time in our day, and it's important that you come educated and, well, not filled with too many questions, because the doctor will help you out, but you've got to understand what they're talking about. If you don't, it's a waste. You're talking about what day it is, how's the weather, and not getting to what's important. So with all that being said, I think we've answered a lot of questions. I'd like to go to Patricia if she's ready. Managing side effects and symptoms, very, very important topic. And I've worked with Patricia before, and I'm thrilled to be working with you again. So take it away, Patricia.
Great. Thanks, Kelly. And I'm happy to be speaking with you this afternoon. Now it's afternoon, I guess. But really what is very helpful through all of this, great information shared already, but let's really focus on the symptoms that people experience and how best to manage those and anticipate those. So we really put whoever the slide we are all artists. This is an art, science. We're learning more and more. There's an art to treating this, and certainly we want to all be artists in your care. So the goals of care, certainly we want to make sure in terms of treating your myeloma that we control your disease. If you're sick and newly diagnosed, getting a quick and effective response to the regimen we decide on jointly, that's a major goal in this, and extending that remission, getting into remission, extending it is certainly a goal we have for overall survival improvement, of course. And then we also utilize supportive measures as well to help prevent further organ issues that can develop, particularly bone issues, pain issues, things like that. Our goal is to really give you the best quality and extent of life that we can. And so there are these are the symptoms that there was actually some meta-analysis that looked at the various symptoms people experience when they have myeloma. And this happens not only in early disease, but throughout the whole disease trajectory with multiple myeloma. Of course, there's the physical changes that people undergo and feel. Certainly fatigue is one of those, sometimes related to the disease itself. Causing fatigue, sometimes it's related to the therapies we give. And so we have fatigue, we have GI issues, like constipation is often experienced throughout various times during your treatment trajectory, as well as looser stools, diarrhea. We know we constantly are dealing with pain, particularly related to bone disease can be painful, or a neuropathic pain can develop as well. And then some other sexual dysfunctions are experienced, sometimes not talked about as much. And that's why it's nice to bring these things up. Psychologically, going through this has symptoms. Here you're told you have multiple myeloma, sometimes depression, anxiety can be experienced. And that's appropriate and understandable. And that's why we're attending these workshops to discuss and educate ourselves to help with these particular issues. Sleep disturbances, certainly we know that came up in some of the questions already today. There can be some cognitive dysfunction. We sometimes term it chemo brain in the various treatments that we give. Some people may notice that, or as mentioned, some of these newer therapies, CAR T therapies and other bispecific antibodies can cause a neuro-related issue. And then certainly there is the whole change of roles. Now you might not be the same. You may not be able to conduct your same job, or because of some limitations of your disease, and so that can certainly impact things. The other thing that's thank God we're talking more and more about it. Everyone does experience some financial toxicities and financial burdens, and so it is one of the things that sometimes can be uncomfortable to talk about, but I think we need to discuss it because it does impact certainly on quality of life and things. So let me see, we'll start first with the toxicities related to steroids. And we know that we often use steroids. Steroids are great medicines that can kill lymphocytes. And we know myeloma is the most mature B lymphocyte or plasma cells. That's what make the antibodies. And in myeloma, one particular antibody is being overproduced. And so it's a very non-specific killer of lymphocytes, but it works very well and synergizes very well with other regimens. So when we talk about triplet therapies, generally or doublets, it's often a steroid plus immunomodulating agent or plus a proteasome inhibitor. We give them with monoclonal antibody therapies and such. So it's a commonly used agent, but as all of you who have experienced this, sometimes there is the dark side of it, and it has some side effects. And listed here, it can cause irritability, mood swings. You may not even notice it, but your family may be noticing it. Definitely people notice insomnia generally very soon after taking the medication. And then sometimes after you stop the medicine, a day or two later, you have a letdown or a very, some people can be more sensitive to these issues than others, but you can have more of a fatigue-like syndrome a few days after taking the dose that's recommended. Can cause cramping, some retention of fluid, and with that, it can sometimes drive up your blood pressure. The other thing is people with diabetes or a tendency towards that can certainly have some change in increase in blood sugars. And so monitoring that is an important aspect when you're on these agents. So there's also some gastritis that can develop from taking it. And so listed on the left-hand side of this screen, I think is very helpful in terms of how we can help, or you can try to better tolerate this regimen. Certainly letting your providers know if you are having any of these symptoms can be a great help, because if we don't know, we can't help you. And so there's always, and through this whole talk, I want to really stress that the importance of sharing your toxicities or your side effects, even though they might be something you don't want to maybe let us know. Please let us know, because we can work very closely and give you some tips if we know this is an issue. But you want to, often some people find that steroids taking it at nighttime is more of a problem. We often tend to encourage our patients to try to take a steroid dose in the morning with breakfast, so it's not on an empty stomach, it's with food. That way some of the toxicities or the stimulatory effects of it is out of your systems before you try to sleep. Others feel, no, that's not the case. In fact, it's the opposite. So there is a trial and error kind of scheduling, but generally once you figure out what's the best time of the day, that's an important thing, and just stick to that when you take it. We often pulse decadron or steroids, and that's a little safer in terms of risk of infection, generally given once a week in most cases. And picking that day, we have some of our patients that work Monday through Friday, and they find that they really have some sleep issues. They generally like to take their steroid on a Friday because then they're have the weekend off to kind of recover from that, you know, and these are all things that you can work with your providers about. Taking some antacids might be helpful, and also certainly medications that can prevent infections, because we know steroid use can increase risk of infection, particularly those that are a little older than 75. Sometimes we'll bring the dose down a little bit because of intolerability. So all of these things are just to highlight and certainly to discuss with your providers. GI toxicities, again, we know that some people can suffer from looser stools, diarrhea. Some can have the opposite effect of constipation. It can be related to medications that we're giving you, either of these. And so it is very important just to walk through the types of medicines that can cause diarrhea. You know, we have people that take pain medications. Often people are requiring some narcotic use, and that we know can contribute to constipation. You therefore start to take you know, laxatives and other medications that may help with that, and then you take too much of it, and then you have this diarrheal syndrome. So that's one thing. We know some chemotherapy agents, as well as antibiotics that you might be on, or antidepressants can certainly contribute to diarrhea. The other thing is supplemental medications or supplements that you might find you're taking for other general health related things may also contribute. So always share with your providers the list of all your medicines, even the supplemental over-the-counter stuff that you may not think is that important might be contributing to some of the toxicities that you're experiencing. We know that salt substitutes can sometimes contribute to diarrhea. The caffeinated, heavily sugared beverage can also contribute to some irritable bowel-like syndromes. And so medications to take certainly with consult with your provider, because we don't want to miss an infection that might be causing some diarrhea and mask that. So, always call your provider and they'll be very helpful to recommend maybe antidiarrheal medications, maybe adjusting your diet. As mentioned earlier, some people can become a little lactose intolerant. And so monitoring your diet and the amount of dairy you take, eliminating some of that can be very helpful. There are bile salt binders that can be very helpful in people that have diarrhea induced by Revlimid. The trade name there is, but it's cholestyramine is one of these agents that can be taken daily and can be very helpful in that. So then just talking more about the constipation, the opposite effect, we know pain medicine, certainly, as we mentioned earlier, and some supplements. We have people that may be on some calcium supplements with vitamin D or not because of some of their bisphosphonate therapies or other reasons. And that can contribute to constipation. People that I guess the best way you can do to help is to monitor your amount of fiber you're taking. We know that increasing fiber can certainly help with constipation, as well as other agents can be very helpful. But really, fluid intake, that we love to push our fluids. Fluids can help you in terms of your kidney function, your normalization of your bowel can be very helpful. And so drinking your fluids daily is a very important and helpful thing. We know pain management certainly impacts quality of life. This is something that may wax and wane. Certainly, I mentioned lytic bone lesions. Some of them can be painful. Having a compression fracture of your spine that can press on a nerve can cause some neuropathic pain. Some medications we take may affect the fine nerve endings in your fingers and toes, and called neuropathy, and that can be sometimes painful. Sometimes it's a loss of sensation neuropathy, but sometimes painful. So there's many different reasons that people may have pain. There's varying degree of pain people experience, and so we do find that certainly trying to prevent further bone loss or painful lytic lesions by using bone strengthening agents can be very helpful. And I know in some of the questions earlier, people are taking these supportive measures of bisphosphonates and such can be very helpful. We know that getting into remission can very much help the development also of painful bone lesions. And so getting into the deepest remission can sometimes help with your pain. Medications, though, pain medications are helpful, but also some other supportive measures, like people may undergo, if they have a compression fracture of the vertebral body in their back, it presses on a nerve, and kyphoplasty or vertebroplasty are procedures that can be done that can actually lift that compression, that crumbly vertebral body off of the nerve and relieve pain that way. That's not 100% that it works, but in many cases it can be very helpful. Radiation therapy, the term we can really sterilize an area of pain that has myeloma growing there. And so we call it spot welding. We just give it sparingly, radiation. We don't want it to affect too much of your bone marrow function, but can be very helpful for painful lesions. And then certainly listed here are the complementary therapies. Some people find acupuncture, yoga, and other supportive measures can be helpful in controlling their painful issues. And so, again, always discuss this with your providers, because we will help if we know about it. If we're unaware, it is something that we can partner with you and really try to work on that issue. The other, again, neuropathic pain, as I mentioned, sometimes can be painful. Sometimes can be loss of sensation. Sometimes it's alteration of sensation. And so it's different for everyone. Often the neuropathy that we think of related to therapies we give tend to be peripheral neuropathy, where they affect, again, there's fine nerve endings in the fingers and toes, but that can worsen and can start progressing up more of your feet, up your legs, and certainly your hands and things. So identifying this early can help your providers and you work together. We often can identify maybe the medication that may be causing it. And so we can dose reduce that, or hold the dose, or switch therapies to something else if it's getting worse. And so making your provider aware, and often when you're on the proteasome inhibitors, particularly bortezomib that's listed here, sometimes changing the schedule. We're pretty much moving more towards a weekly dosing of that, because it does have less toxicity, but there may be some providers that are still utilizing, for various reasons, a more twice a week approach to the bortezomib or Velcade. Subcutaneous administration has been helpful to lower that toxicity potential, but it's not zero. So altering that is very helpful. Listed here, some other things patients have found very helpful are massaging your feet and hands using cocoa butter, using supplements. The B complex supplements can be helpful in even some people start them prior to even having some of the neuropathic issues, but even if they're early, adding them in can be very helpful. And remember, safety is an important thing. And if you are having alteration in the way you're feeling the floor, your either numbness or sensitivity, you're more at risk for falling and tripping. So having a safe environment in terms of rugs, you may not notice that. Or I always think if you're taking a bath and you step into the bath, you always want to check the water temperature, because you might not be feeling it. You want to avoid a burn or something like that. And so we really can work with you to adjust the schedule and alter the therapies to make this, certainly we want to prevent this from getting worse. And working with your provider, again, is very helpful. So the emotional aspects to this diagnosis and the therapies can be, again, as we mentioned in an earlier slide, fatigue related to the disease itself. Often people have a low red blood cell count. The hemoglobin that carries the oxygen to our tissues can be low and can definitely cause fatigue. We know the medications themselves have a component of potentially causing fatigue. and also just emotional fatigue and having chronic pain that's not being controlled can certainly contribute to pain. Anxiety, depression can also be experienced, again, reported here, 35%, more than 35% of people will report some anxiety during their disease. Depression is often as high as 25%, so it is a real issue. It is nothing to hide. It's something that we can help you with. Again, the financial concerns as well. We have options of, the financial burdens will highlight a little further, but we have access to social workers and other people, supportive team members that can be helpful in dealing with some of those issues. And so always being aware of those is helpful. In terms of staying healthy and well, of course, resting and having a healthy lifestyle can be very helpful. One of those is certainly sleeping, can be very helpful to just your body healing and maintaining. And so, sometimes there's days that this might be more of a challenge, particularly on those days of steroid use. And so there's certain things you can do with altering schedules. Some people find that taking some herbal tea or a warm drink prior to sleep may be helpful. Avoiding naps during the day. If you have difficulty sleeping, sometimes it catches up to you in the middle of the day and you find yourself sleeping on the couch. That also can cause worsening issues with sleep later that night. And so trying to also stay a little active, the more active you are, the more tired you are for sleep at night. And so all of these things can be certainly experienced, but these are some tips to hopefully help you sleep better at night. Sometimes we do use some medication to help you on certain days. Getting too dependent on them is never a good thing. And sometimes they lose their effectiveness if used too much. Dietary changes. I like this last one. I know personally, if I have a caffeinated drink too close to bedtime, I'm staring at the ceiling sometimes. So, or a larger meal may not be the best to do right before you're planning to lie down. So those things can be important, as you know. So listed here are the financial burdens. I think we all know everyone does experience them to a great extent, even if you're on therapy or just even coming to the doctors. We have these out-of-pocket expenses along with the real medical cost of what your insurance covers or not. Oral agents can sometimes be very costly because it's on their prescription benefits, not their major medical coverage that some of the other agents are covered in the clinical infusion area or inpatient. We know that it impacts your livelihood in terms of if you're unable to work, it can impact your income. And these are things that are very, very appreciated and certainly can happen. So listed here are the funding that can be available, and many of there's some federal programs you can access. Pharmaceutical support can be helpful for some of the costs of medications, but I would say a lot of nonprofit organizations can be helpful as well. And listed here are the various Leukemia Lymphoma Society, Needy Meds, Health Well Foundation can be helpful for some copay assistance. But really tapping into your social worker can be very helpful to help you identify the various potential help that you can have. But we understand that this is an issue. Even just the out-of-pocket costs of traveling to the physician, the parking, the time away from work, we do appreciate that. But the other aspect of, just to get through this quickly, is the infections. You know, we know that people with myeloma have immune dysfunction. We know the disease itself can contribute. Even in remission, we still consider you have some immune dysfunction, and then adding to it the treatment you're on can also contribute to that. So we know that there is an increased risk of infection, bacterial infections, or even viral infections. Reactivation of your chickenpox in form of shingles is not an uncommon thing, and some medications we're giving you can add to that risk. And so having antiviral, preventative, or prophylactic medicines can be very helpful. Giving antibacterial antibiotics at high-risk parts of your therapy when your blood counts are low, or we're expecting them to go low, can be important to prevent infection. But monitoring fever, we take it very seriously. A fever greater than 100.4 is listed here, or chills, can be very important for you to report immediately in the middle of the night to your provider. This is not something we get bothered by. Oh, I don't want to wake the doctor in the middle of the night. Wake them, because they want to know if you're having these, you know, when your temperature is that high and you're in the context of therapy or something, we don't want you to get sicker without attention. So that is something to bring to your provider's attention, along with, again, a chill can be a sign of an infection. Some shortness of breath. Many of the infections that we experience bacterially can be pneumonia or upper respiratory tract infection, sinuses or bronchitis, things like that. So it's helpful to be aware of that. Certainly, what can you do to prevent that? You know, personal hygiene, always important. Washing your hands, and staying, you know, away from people that may be sick. And in crowds, we know we never know who could be sick. And, you know, certainly in the era of COVID, throwing on that mask can be very helpful to prevent risk of infection. Using therapies, not only antibiotics or antiviral, but growth factors, medicines that can stimulate your white count if it's low, can be very helpful. Getting immunization, getting vaccinated, but we do encourage people to get the COVID vaccines. We do encourage patients to get the flu shot every year, the pneumonia shots every 5 years, but no live vaccines, and is an important aspect. We often try to avoid that because of your immune dysfunction. You might, you know, live vaccines might be a little riskier for you to receive. So lifestyle strategies, and as I mentioned earlier, staying active can be very helpful, not only for your mental well-being and your physical muscle strength and flexibility. It can be very helpful. Some people report that with some mild activity, nausea can feel a little, can be better if you have some nausea related to any of your therapies. So that can be helpful. The other things listed here for lifestyle strategies is to some people find keeping a journal of your activities and highlighting, oh, you know, I wasn't so active today, but boy, I felt better on the days that I did this or that, can be very helpful. You don't want to overdo it as listed here. You don't want to compete with your body for restoration and things, but staying active can be helpful. You know, being with bone related issues, some of us really, some patients do have some weight restrictions. We don't want to cause a fracture of a bone in a weakened area. So lifting heavy weights might not be good for you. And this is always a discussion with your provider on what the best form of exercise may be, but some mild weights can be very low level poundage weights can be helpful. And so, and these yoga, Pilates, and other forms of exercise can be very pleasant and things. A lot of our patients find that swimming has less stress on your actual bone and body and can be very helpful for flexibility and endurance and things. And then again, the pandemic really did throw a wrench into our lives, not only everyone, but certainly in more of a concern for our patients that are immune compromised. And so with that comes the fear and the worry, like I want to have quality to my life, but am I putting myself at risk if I go out? So again, that's always going to be something that you should discuss with your providers in terms of at what time are you the most risk at being around other people, but certainly practicing hand washing, getting vaccinated, wearing a mask in those high-risk areas can be important to prevent an issue with COVID. But you want to try to stay as active as you can through that time, but we do identify and recognize the stress that this can all cause, and hopefully someday we'll be improving shortly and getting out of it. But just the final points here is we really feel that we have so many options, as you've heard, in initial treatment, should you do a transplant, shouldn't you do a transplant, maintenance therapy, supportive measures. There is a shared decision in this that you are as vital a participant in your care as your healthcare provider is, and both of you bringing data from all your research and but more importantly, what you want your life to be, what preferences are important to you, can all play into the proper decision on treatment options. And it is a discussion, and it's really, truly a shared decision-making process. And I won't spend too much time on this because this was previously discussed, but again, clinical trials is very important. As you know, it really has been people before you, and maybe you have even participated in clinical trials, has really driven the treatment options for our patients by participating in clinical trials. And it really helps us. So the phase 1s are more early in terms of toxicity profiles. A phase 3 is really comparing a new agent or therapeutic option to the standard and things. So these are just the various phases that you could participate in. And listed here are the various ways you can find out about clinical trials through clinicaltrials.gov. Also, the IMF has availability to letting you know of various trials that may be open, and certainly discussion with your healthcare provider and myeloma doctors can be very helpful to this. There is some miss with clinical trials that, I don't want to go on a clinical trial because I might be placed, if I'm randomized to a placebo, it may not be helpful for me. And that's never the case. It's always, whatever the option might be is always against a standard approach and things. So we feel that everyone is a potential candidate at various lines of treatment. There's clinical discussion or questions that we have for initial treatment. There's certainly discussions and treatment clinical trial options at transplant, as maintenance questions, as well as at relapse disease. And again, as I mentioned, it really is something that has driven the treatment options available to our patients by the really robust participation that we have by patients. There, is it more expensive? I like the final one here is many of the clinical trial question in terms of a new agent or something, that cost is not accrued by the patient. That's usually sponsored by the trial itself, but out-of-pocket expenses of other routine stuff that are happening along with that would be covered by your insurance. I think that is an important thing. And if any of you have been on a trial, certainly the trial group will discuss all these things with you. And always, some people have the myth that if I enroll on this, I can never get off this trial if I don't want to stay on it. You can always take yourself off a trial with no ill effects or anything. And so these are more myths than reality. And always, to be the most involved in your care, to prepare for your trial, your visit to the physician, is to jot. I always find that sometimes people get lost in the moment when they're sitting there and they're like, they walk out of the office, drive home, and as they're driving home, they're like, oh, I forgot to ask that question. And so keeping a list, just having, so I always tell people, like, everyone has their iPhone near them. So just jot a little mention down and keep a list. And then before you leave the office, you make sure that every one of your questions was addressed and answered to your liking. But always let us know about the symptoms you're having or the financial toxicities you might be experiencing, because we are there to help you. And we want you to do well. We want to extend your life and your quality of life. And so we work together for that. Another option in the world of that we live in right now is telemedicine options. And sometimes that can be very helpful. We certainly found it very helpful early in the pandemic. At least some of those options of out of state, at least I work in the city of Philadelphia, and we can still do telemedicine visits for in-state, but we're losing some of the option of people that live in other states. They might need to really travel to our center now. That's kind of changing a little bit, but always look towards telemedicine options for follow-up and things, and getting lab work ahead of time can be very helpful if that's an option for you, so that you actually have recent and up-to-date data for your providers to discuss with you at the time of the visit. This listed here, the IMF, I cannot speak highly enough of the various options of information and educational material in terms of disease-specific questions, symptom management, drugs that you're on, everything you can think of. There's also, like the conference today, there's teleconferences that are scheduled throughout the year, as well as newsletters that you can access through your emails and things. So always accessing myeloma.org is a very helpful way of staying well educated and up to date on many of the things involving myeloma. And so I will end there, and I hope that was helpful to you in terms of some tips and strategies for symptoms that people can experience. And I'll open it, give it back to Kelly, but if there's any questions, I'll be happy to entertain them. Thanks.
How about now? Can you hear me okay?
Yeah.
I don't know why my computer is doing this. I'm sorry, everyone.
Okay.
Patricia, very thorough.
I thought I put everyone to sleep.
No. Your talk's important in a combination of the other doctors' talks. It's now remember, we used to do this from 9 to 3, and now we're doing it in 2.5 hours. So it's intense. And for you, those of you watching, just remember this is all recorded for you. It will be on our website on Tuesday. So listen, I want to go over 2 questions here quickly. Metformin to manage steroid-induced hypoglycemia. Is that something that happens out there, Patricia?
To manage
Hypoglycemia. Go ahead.
Well, it is a blood sugar lowering medication that does need to get prescribed by your physician and things. So it's something that can be helpful for sure, but it depends on the individual and their amount of blood sugar issue and things. So it really should be managed more directly, but yes, it definitely can lower blood sugar. But sometimes other medications may be utilized. Sometimes people require blood sugar monitoring, finger sticks at home, just if they really do have underlying diabetes, because it can really shoot up your blood sugars and things. So sometimes monitoring that throughout the day can be very helpful to very actively manage your blood sugar issues.
Right. And now this is a tough one. I've heard this before in questions. Is there a way to determine if one has experienced fatigue or standalone depression with multiple myeloma? Mm-hmm. So that's a tough one. I'm tired, but I'm kind of bummed out, for lack of other words. Is it being tired or being bummed out that's causing this?
Well,
with both of them?
Yeah, well, I think you're right. Sometimes it is a little confusing. So we always, if you let us know the fatigue, describing that to us, we do thorough blood work. If it's contributing, if it's related to anemia, then we're monitoring that. If it's related to medications, we'll review the medications you're on. And sometimes in the discussion with your provider, you may be sharing not just fatigue, but I'm also feeling down. Sometimes it can contribute to sleep disturbances. So we would then, it's really a nice discussion with your provider to figure that out. I'll open it up to the other physicians if there's anything else that they like to use to ascertain a physical related fatigue versus a more emotional depression-like fatigue.
Doctors, you'd like to comment on that? Craig, first?
Yeah, there are definitely the medications can affect the mood, and especially the dexamethasone can really play havoc on that. Mm-hmm. And I think one good thing is to definitely talk to your doctor and providers about it. There's a study that found that about 60 to 70% of patients that have depression don't discuss that with their providers unless they're asked by their providers about their mood. So definitely talk. There are actually depression surveys and scales that can help tease that apart and look for symptoms that are very specific to depression that really aren't part of a medication effect. But I think but in order to engage some of those tools to help determine if someone has true depression versus an effect from low calcium or medications is to engage your provider and help them with that, because the important part is that depression and is very treatable and just like Patricia had mentioned, very common with multiple myeloma.
Great response. Jesús, would you like to add anything to that?
Yeah, I don't have much to add other than then yeah, it's a very difficult symptom. And you know, I think the hard part is that some people may have presented with that as a symptom when they were first diagnosed. And I think that fear that something is progressing, and it's this vicious circle. And Craig is right, is I think most patients are afraid to kind of discuss their fears about this. So I find it I personally, I think I need help. So at least in my experience, it really helps to involve the palliative care teams and psychology to sort of to kind of help sort of navigate some of these potential other issues that can really complicate the treatment. And again, the important thing in myeloma is maintaining therapy. So all these things that Patricia talked about are incredibly important, because at the end of the day, we can prescribe the right medications. If you can't take them because of side effects or because they're making you feel bad or for whatever reason, then they're not going to work as well.
Craig, is this active observation?
It is active. It is active participation.
Oh, okay. Not observation, participation.
Yes.
That's fantastic. Now it even makes more sense to me. I wasn't sure. Listen, y'all, can't say it enough. You are all very special to me in my heart, and for what you do for the patients. Very thorough presentation for all three of you. Can't say enough. The IMF is grateful. I am grateful. And of course, you can read all these and listen to them. Here's a segue at myeloma.org. Get on that website, start learning some stuff. But after this talk here, before we finish, answer the questionnaire for me. Do it before you stand up. And then after that, stand up, gently stretch, and go seize the day. And understand that that's the way to do things. Get through it. You can deal with this disease, I promise. With all that being said, adios, friends.
Thank you.
Thank you.
Sponsors,
Bye.
one more time. Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, and Takeda. There, got it all in.
Yay. Bye, everyone. Good luck.
Hands off. Thank you all. Bye-bye.
Yep.